Okay, so just to kind of review a few slides before we get into the cases. The extracellular contrast moves into the extracellular space as early as 90 seconds, and Eovist enters the hepatocytes as early as 90 seconds. But early on, can you see this? Both arterial and the portal venous phases are equivalent for both extracellular and hepatocyte-specific contrast. So those things that take up Eovist, generally we think of FNH, or regenerative nodule, or occasionally HCC that has this organic ion transporting peptide expression that allows it to uptake it. And things that don't take up Eovist include most of these other non-hepatocyte types of lesions. So this is from Cloud Serlin, and you could see Eovist causes the tumor to have increased signal intensity first, and then the liver catches on later. So here are a couple examples of the same lesion imaged with extracellular contrast versus hepatocyte-specific contrast. Here, this lesion you could see is a hemangioma. It's classic, but with Eovist, although it does follow blood pool, it just doesn't show it as well. And then here is another one. We have this peripheral discontinuous nodular enhancement that's classic for hemangioma, but with the Eovist, you could see that it's pretty much dark on all of these phases. So it can be a kind of a diagnostic dilemma sometimes. Okay, so this is LIRADS. And this is a LIRADS 5 lesion that does not require tissue diagnosis. So here's, I have maybe 5 cases. So the answer here is
it's more like an FNH. Wait, oh, just kidding. Sorry, I take it back. I take it back. My bad.
It looks like it wants to be something benign.
Yeah, it looks like it's got pseudo-washout, like it's like bright on the pre, and then kind of equivalent on the arterial, and then on the venous, I wouldn't say that's washout because you don't have the arterial hyper enhancement, so it's like pseudo-washout.
Yeah.
So some kind of like focal fatty sparing, or
yeah. So that's I'm glad I'm showing this. It's kind of curious. It ends up being probably focal fat, but I just don't understand. And I revisited again, pulling up this case. This is indeed denser than the rest of the liver. So this, on all other CTs that this patient has remained stable, and this is focal fat. Somehow on this pre-contrast phase, though, it is just denser than the rest of the liver. But on all other sequences and all other studies, this is showing up as focal fat.
Why wouldn't you just say the rest of the liver is fatty and this is a regenerative nodule that is fat sparing? Like I don't see this as focal fat. I see it as a fatty spared nodule, like probably, and in the setting of chronic liver disease, like a regenerative nodule.
I think that's a even. I think that would be a even better explanation.
Because on that pre-contrast, the liver looks fatty.
Yeah.
Yes, on the pre-contrast, the liver does look fatty.
Which I think is kind of a good point. Like the liver does a lot of regeneration in these patients with chronic liver disease, and so those nodules don't necessarily, they might end up sparing fat or have a different kind of composition.
I just figured out why you guys couldn't hear me. I was muted the whole time. Here I am wagging my jaw saying, nobody's paying any attention to me. Totally agree that this is fatty sparing, whether it's a nodule, a regenerative nodule, or just liver. It's hard to tell. But yeah, the background liver is steatotic. I mean, if you showed the spleen in the same image, I think we'd see that visually with our eyes, or we could put an ROI on it. But and then I agree on the delayed. You're not going to call that unequivocal washout or encapsulated. It's even, it doesn't show arterial enhancement. So
Steve, we can't hear you well.
really, still can't hear you well. Okay.
That's a little better when you came closer, but.
Maybe I just need to shout. Anyway, I'll shut up now.
So focal fatty sparing.
Mhm.
Okay, what I originally had it. Just thrown off here. All right.
Nellie, you want to give it a try?
Oh, sure. Hep C liver lesion, best classification. It doesn't enhance really. It doesn't really wash out either. I mean, and it doesn't take up Eovist. And it's T2 intermediate. So it can't be 4 or 5 because it doesn't really enhance or wash out. But it doesn't look benign. So I would give this an M. LR malignant, needs biopsy.
That's correct. Yes. So we encounter this at least once a month. Patients are getting a liver transplant evaluation, and they in fact have metastatic disease. This is the PET, and this was this lung, and so this is actually a metastatic lung cancer. So by definition, M is high probability that it's malignant, but not HCC specific. And 94% of these end up being malignant per the LIRADS manual. And most of these, actually, almost half of these are a plurality of these are gonna be HCC. But the criteria here is targetoid dynamic enhancement with either rim arterial hyperenhancement, peripheral washout, or delayed central enhancement. I think we had rim arterial enhancement here. So what about this one? Saw this case 2 months ago.
That also looks like an LIRADS M.
Mm-hmm.
It's got, this one has arterial enhancement, doesn't really wash out convincingly, and actually has, this one actually, maybe it has 2 components. Like one appears, the lower part of it seems to have delayed enhancement, and then the upper part has like arterial enhancement, but I'm not sure about washout.
Mm-hmm.
So I definitely call it at least an M. Mm-hmm. And you can get some like HCC cholangio combos. So I guess it depends on if you were going to say there was washout in that upper part of the lesion, but otherwise I would call it an M.
Yes, yeah. This was read outside as, it's very highly suspicious for HCC. They didn't give a LIRADS classification, but this was biopsied, and this woman ended up having a metastatic breast cancer. For some reason that I don't understand, this went to ablation. And they successfully ablated it, but on the follow-up, she got 3 more lesions.
Mm.
This is an interesting case.
So there, I don't see a liver lesion. Am I missing? There's a splenic lesion. Lots of, huh?
You're not alone in that. The fellow from 2 years ago also thought that was a spleen or something.
It's coming off the edge of the liver, Nelly.
Oh gosh. Oh.
You see, there's a space between that and the spleen. Actually, that's a classic blind spot. Is like lesions that hang off the tip of the liver.
Okay, got it. Okay, so there's a ginormous.
I remember that's exactly what the fellow said. There was no.
Well, I'm in perpetual beta mode, so learning.
No, me too. Yeah. Me too. But so then we point out this lesion, and it has Eovist uptake. Looks like.
Okay, so there's enhancement. It becomes ISO, so it could be. I mean, you can have green HCCs. Like a super indolent low grade can take up HCC, but that's not that common. It, I don't feel comfortable calling this an FNH. It's too heterogeneous to be FNH. Hepatic adenoma. I wouldn't. Patient has hepatitis B, so you can't call it adenoma because the patient has background, diffuse liver disease. It doesn't look like a MET to me. It looks like a primary liver lesion. Hemange is not T2 bright enough to be a hemange. So I would, because of her background, I would give this. Gosh, I want to give it a 5, but I can't because it doesn't fit the classical. I would recommend biopsy, LR4 or LRM, because it could be a green HCC, but you can't call it a 5.
What you said. I said this could be a green HCC, although afterwards.
Well differentiated. So it's
People ask me, I think somebody asked me, how did I know that it wasn't an FNH? Because there's Eovist uptake, and the answer is it just looks too ugly.
Yeah, it's heterogeneous. Yeah.
Yeah, and it's not going to be an FNH, although we left that as a less likely possibility, but clearly here on resection was a HCC. So
what is this term you guys are using? Green?
So yes, this green HCC.
New to me.
Oh, okay.
It's because of the bile production of the HCC causes it to stain green on the pathologic specimen. And this group, this paper actually correlated all the past specimens with the Eovist uptake. And this Eovist uptake is correlating with that bile staining on formalin fixation. So it actually does look green.
But they're indolent, like they're on the indolent spectrum. They're well differentiated.
Low grade HCCs, right?
Mm-hmm. Mm-hmm.
Cool.
That is actually what I always thought, that it was well differentiated.
Mm-hmm.
This paper actually is suggesting that it doesn't correlate as well with the differentiation. Yeah, so that's something that I learned from reading this paper.
And did you compare it to any reported case reports of so-called atypical FNHs? I guess that was your backup differential, but whenever I get something where I see hepatobiliary phase uptake, and I'm like, well, I know there's some FNHs out there that can look kind of strange. Does mine look kind of like one of those? And then I start looking for case reports. There are some case reports of FNHs, because they end up going to resection also, that can look kind of weird. And I wonder if you just did that.
Yeah, I'm sure there probably are, but I just haven't seen that weird.
I've had a few cases of that, and I would say exactly that especially when they get like really big, they start looking really weird. And you basically can't tell the difference unless you biopsy it. And then biopsying an FNH can be challenging because it's like disorganized liver tissue. So you really need to get a lot of big cores and stuff. Otherwise, they'll be like, these are hepatocytes,
All right.
With something that looks like that, it's not hard to talk a surgeon into taking it out to know what it really is.
No. Okay, last case.
Steve?
I can talk. I don't know if you can hear me.
Yeah,
you're good.
Okay, T1 in phase, you have a T1 relatively bright lesion. And then on T1 out of phase, looks like you have a rim-like India ink artifact showing you a lipid water interface. And then arterial phase, hard to tell if that's enhancing at all or not, but it's certainly not enhancing greater than background liver, and then on venous phase it kind of ends up looking the same. The images look like you're seeing something that has a high concentration of gross fat, or if not all gross fat. You can get myelolipomas of the liver. Your A says adrenal though, so I don't know. Hepatic myelolipoma. A colonic appendage is another idea. When they end up in this location and are fatty, they can be what's called pseudo-lipoma of glycine capsule. Then they can show you a fat-water interface. It's really on the surface of the liver, even though it looks like it's in the liver. It's actually wedged between the underside of the diaphragm and the liver. Ovarian teratoma, I'd say no. Pleural plaque, no. Ulcerative colitis, no. And perirenal or perihepatic fat, no. So I'm going to go with, how about the pseudo-lipoma of glycine capsule, or old colonic appendage.
Very nicely done.
I'm a ringer for this case because I wrote a paper on it.
Oh, wow.
If you look it up, it was in abdominal imaging about 5 years ago.
Yes. Yes, we love the few cases of this that we have here. But the current explanation is exactly what you said, piece of colonic epiploic fat that becomes ectopically located in the liver capsule, which sounds like the most ridiculous thing to people who haven't heard of this entity. But that is exactly what is thought to be the reason for this.
For a long time, running up to my writing this paper, people around my department just called it the thing. Hey, look, there's the thing. Send that case to Dr. Eberhardt. And I'd saved about 40 cases until I finally figured out what it was and read that specific entity, and I'm like, oh yeah, and then I finally published all the cases. So somewhere out there, Strickland is the first author, and I'm like the second or third author, whatever. I think there's only the two of us. Or maybe actually it was the first author.
That's when you peaked. The peak of your career.
Maybe. But they calcify. So if you see them on CT, if you see like a calcification on the surface of the liver, especially in this location, it's often one of these that's calcified. And then go back in time, and you'll see that it evolved out of something that was fatty.
Nellie, why do you think you get stuck there between the liver dome and the diaphragm?
Why does it get stuck there? I mean, you've got, at the bare surface of the liver, it's like adherent to the diaphragm, so you can't go in between there. So you're limited by the anatomy.
But why does it even go up there? How does it, why?
Why does it go up there? I don't know. Why does it go up there?
Who's giving you a clue?
Who's giving me a clue? Steve? What did you say, Steve? Repeat what you said.
Look, he's making a gesture like this.
Oh, I can't see him. I only see the people that are talking.
Oh,
Here, I'll change my view.
Was showing kind of a swirling pattern, a pattern of down in the middle and then up along the sides and then up underneath and then back around again, maybe through the leaves of the mesentery.
I mean, I know like the perineal, the fluid, it circulates in a circular pattern. Is that what you're talking about?
Exactly. Right.
Which so then, for example, ovarian mets, that's why they, metastasize in the pattern that they do, because of the peritoneal fluid, which has like a specific pattern of circulation.
Exactly. It's the peritoneal cycle. And it can, that's why things often get trapped between the liver dome and the diaphragm. So for example, endometriosis, the way that it gets to the lung base is that it gets pushed up there by the peritoneal cycle, and then it goes through fenestrations in the diaphragm, which is why you usually get it at your right lung base and not your left. On the left side, it doesn't usually get above the spleen unless they've had surgery, because the splenorenal ligament blocks it.
Got it. Okay. Awesome. Perpetual beta.
Great.